tell was he was probably, I'll recap in a second for the folks on YouTube. He was probably like 30s, 40s, I could tell. Later confirmed to be like 33. And he was in a wheelchair. He was kind of like sitting in the fetal position, vomiting. So I'll stop there and ask you, what thoughts would cross your mind in any space, diagnostic, treatment, anything? And we'll get some more information in a sec. Are you all stunned in silence because of how empathic you are? Oh, okay, Rafa, take it away. I said you know everything. Tell us more.
No, I was thinking, what could lead a patient to have a lot of vomiting? And then I thought about toxins, especially like food or maybe other type of drug, but also like occlusion. You know.
I love it. Amr, please jump in.
Well, I was thinking about either direct irritation to the stomach, so or any nearby parts of the GI, such as infections. Probably something like this is more acute, I would think of, or by toxins such as alcohol, let's say.
Beautiful.
Or another thing I was thinking about was obstruction, but I really forgot completely about the neurological irritation, which is perhaps extremely important.
Yeah, I absolutely love it. Ravi, jump on in, please.
Yeah, my sort of initial approach is looking at all the systems that could be potentiating the vomiting. So CNS issues like increased intracranial pressure or irritation, infections into the CNS area postrema where you do get some, I guess, in the brainstem, uremia and things, toxins can possibly trigger that area and induce nausea, vomiting. And then vestibular, so their balance is off, they may have nausea, vomiting. And then, like many have mentioned, the GI bucket, so anything that could insult the GI system.
100%. I think that's absolutely superb. Shema has an example of what can cause an area postrema syndrome. Shema, can you enlighten us?
Sure, there are these neuromyelitis optica spectrum disorders, and as one of the criteria is also this area postrema syndrome that is possible there. So this is always something that reminds me of it. That's why I wanted to mention it.
Oh, absolutely. Superb. Thank you so much. That's such a really good fact to know. Gurbani, hello. Welcome back. Do you have the ability to unmute?
Yeah, hi.
It's nice to see you. Tell us, you haven't been on VMR in a while, at least is when I've been on. What are you up to these days?
I'm currently on a sub-internship, so sub-I season has started.
All right.
And
is it your medicine sub-I or another sub-I?
No, this is my ophthalmology sub-I.
Oh, nice. Cool. Yeah. All right. Master of the eyes. That may or may not be relevant today, but can you tell us what you were saying in the chat so folks
yeah, so I was just thinking two other things. One, to add to the GI bucket, was esophageal perforation or Boerhaave syndrome, which is like unrelenting retching. You can have crepitus as well as usually like pain radiating to the back, which this was just like hyper emphasized on my surgery sub-internship. So that's why I was bringing it up. And then the other big one that I think is really important, especially in a young person to think about, is psychological stress. Although this is something that you obviously want to think about as like after you consider all other like medical things, but it is a common, especially in the context of the current pandemic. A lot of people are undergoing a lot of psychological stress.
Yeah, I love it. I think that's absolutely superb. All right, y'all. Now you get to practice what it's like to not be handed data. You know, the truth is we lean so heavily on our nurses to give us data in a sequential manner. And a lot of it, you don't even have to think about. So I'm not going to tell you anything about the case without you specifically asking. So go ahead and ask yourselves and then type in the chat, what is the single most important thing you want to know next? You only get one piece of information, and that information can be an answer to a specific question. It can be a single piece of objective data like vital signs or a hemoglobin. So what would you like to know next? Nara is not happy with this question. Huh. Okay. All right, there's a wide range of questions. I will answer them. I was most curious about the vital signs first because I think that would have pushed me to act much quicker. And here they are. His heart rate is 130. He's afebrile. His blood pressure is 110/70. He's breathing at 30 breaths per minute, setting 98% on room air. Before I give you another piece of data, does this data change what you want to do right now? So what would you do in response to this piece of data? Okay. All right, let's get practical. So what needs to happen before you give this patient IV fluids? Right? Most of us, a lot of us, I assume, practice in the inpatient setting where an IV is in place. This is a patient who's coming off the street, right? So you have to make sure this person has access. So yeah, placing 2 large bore IVs is the single most important thing. In fact, I would say you had evidence to get immediate vascular access well before the data point that I gave you. So in asking yourself, if you are the sole person responsible for this human being, when you see somebody retching and vomiting like that, you need IV access, period. And that is not something on most of our minds because another profession does that for us, namely nursing. But there are times where you might need to step in and help with that. So next time I would say the first piece of information was probably enough for us to get IV access. What would you do with that IV access? Say you have 2 IVs, how would you want to use your IVs? Thoughts? What do you think, Shema? You have 2 pieces of fluid. Amr wants to give saline. What do you want to use the other one for?
Oh my gosh, so you're asking me which kind of fluids I will use?
No. You have 2 IVs. The team is very vehement that he should get fluids. Any other thing you want to give him?
I mean, usually I would also consider giving vasopressors, but not in this state because I think the blood pressure is still stable, like 110/70. Usually when the systolic blood pressure would be below 90, I would consider giving vasopressors.
100%. I think that's absolutely true. That probably should be on your mind, honestly. And depending on where you practice, you might already order them because sometimes getting vasopressors to the bedside takes a little while. So I completely agree with that thinking, Shema. And honestly, with that heart rate and with that soft blood pressure, you might just put the order in for vasopressors and just have them ready. Amazing. Any other ideas? I think Allah is suggesting something in the chat. Do you have the ability to unmute?
Yeah, I was thinking about giving him, I thought about hematemesis, we give the patient BBI and anti-emetics. So I thought this might help this patient.
You know, when superb, that is absolutely correct. You know, when Gurbani was teaching us earlier that patients can get Boerhaave esophageal rupture, that's not a cause of nausea and vomiting primarily. That's a complication of nausea and vomiting. And this patient is retching so much that you have to give them antiemetic right away. So if we're being precise about what should happen, every single piece of data point, just seeing how much retching he had, I think the best step would be not a single question. IV access, fluids. If you have to do one thing at a time, you would probably get IV access right away. No words. IV access, fluids, and antiemetics. Superb. And then you would start to think of your differential, which I think is superb. It really is. This is not just nausea and vomiting. This is severe refractory nausea and vomiting. And I think it prioritizes an intracranial cause, a cardiovascular cause, and an abdominal cause. So I would say in this space, you want to use your HPI and for it to be your neuro exam at the same time. You want to ask a quick history. Hey, when did this start? But at the same time, watch the patient, see if they're moving all extremities, see if their head hurts. And then at the same time, you want somebody to be getting an EKG. I'll ask you all, What is your favorite antiemetic? What do you use for nausea and vomiting? Amazing, Rafa. Can you teach us more?
Well, at the VMR institution, we use bromopride, which I think is effective but not as expensive as ondansetron, which I think is more expensive but more effective in a way.
I love it. I love it. That's superb. Thank you. Wallace, do you want to teach us what you use?
Well, I've seen a lot of ondansetron use. There's I'm not actually sure what are the indications, but I can remember that this type of medication can act in different mechanisms of the vomiting physiology. So it would be a safe choice, maybe a good choice, actually.
Absolutely superb. So you have many options, and Allah is reminding us that metoclopramide is also another great option. So let me give you this. His EKG is sinus tachycardia with no ST or T wave changes. However, his QTC is 600. So what does that do? How does that change or influence your options for antiemetics? Avoid metoclopramide, avoid ondansetron. All right. My favorite learning point. You don't have to avoid anything.
I'm so sorry.
Oh
no.
I think Danielle, I think it's you, but I think you're freezing. You're good? Okay. So
could you repeat? I'm so sorry. Could you repeat the EKG?
Yeah, no problem at all. The EKG showed a QTC of 600. That's all. Got it? Yeah, I see it there. Perfect. Okay, so there are all these concerns about QTC and antiemetics are all hypothetical and theoretical. The medications do prolong the QTC. The relative risk of an adverse event is less than 1 in a million. So much more harm is done by avoiding these medications and prolonged QTC than not. And I don't have it with me. Actually, I'll try to send it out on the VMR listserv. There's a great talk that one of the residents who you might know from VMR, Dr. Rob Weber, did on this at our local institution. He did it in collaboration with Gurpreet Dhaliwal. And they basically showed us that the rate of adverse events with this is infinitesimally low and certainly not enough to justify withdrawing incredibly powerful medications for the patient. So you don't need a QTC, just give the patient a medication. It's one of those things that we worry about, but it doesn't translate much to real life. Now, I recognize a lot of you have to work with other people and get their approval for the things you do. And so you don't have to necessarily push back because it's a very, very, very deep-rooted thing. But in your future career, reconsider it and or reconsider looking at the data directly yourself. I think you'll be underwhelmed by it. So he got, immediately he got, I opened his chart when I saw him and wrote for 1 liter of normal saline, or actually 2 liters of normal saline. Let's have a quick conversation about what fluids we can give, which I think Shema was fearing. So Shema, what are your options? What do you consider?
So I know where is this a saline solution, but you also have this colloids. And what I remember is don't give colloids in a shock situation. Am I wrong or not?
Oh, my friend, you're never wrong. All of us are always, all of us are always at least a little wrong. And the goal is to get closer and closer to our working idea of what the truth is, which also, by the way, changes all the time. So I don't think it's possible to be wrong. But I'm curious what, yes, the German healthcare system is more advanced than many others with a lot more money. Yeah, so Alex, do you want to tell us how you think about this? I think your point here is maybe zoom out from your point and kind of explain what you think about before and then why the situation is different. Because I think you hit the nail on the head of what I was trying to get at eventually.
So what I was thinking was that, starting to drizzle a little bit here, what I was thinking was that typically, so I know somebody mentioned balanced crystalloids. I think the reason why we might think about balanced crystalloids as opposed to saline in most situations is that we worry about inducing an acute kidney injury as a result of giving somebody a lot of fluids with a lot of acid in them. But in this instance, this is somebody who's vomiting a lot, probably has a metabolic alkalosis. So it might be okay to think about saline, especially if that's something you can get at more quickly. And to Seamus' point about the colloids like albumin, I think that's probably fine in most situations. I think there's some theoretical risk that you could induce cerebral edema. So to Ravi's point, that this is somebody who could have an intracranial process going on, we don't know. I think I might lean a little bit away from a colloid, at least for now.
Absolutely superb. I think to outline it simply and to use all the data that Alex gives us, you have three options. You have normal saline, you have what's called a balanced crystalloid, and there are two examples under that. Plasmolite and lactated ringers are the most commonly used. And then you have colloid, with the best example being albumin. I would say as a general principle, if you're beginning to learn this field, you should avoid colloids in most situations and use crystalloids. And crystalloids, you have the option of an acidic-based solution like normal saline, or the other ones being lactated ringers and plasmolite. And I think that in most situations, people use normal saline because it's cheaper and much more stocked and much more available. But if all things are equal, you would only use normal saline in a situation where you are expecting the patient to have alkalosis. Why? It's because otherwise, normal saline has been associated with doing two things: precipitating a non-gap acidosis and also inducing kidney injury in patients in whom a large amount of normal saline is given. So this is a situation where you're doing something a little bit less common by giving normal saline, but I think most people still get a lot of normal saline for three reasons: habit, cost, and stocking. Questions about that? Okay, let me give you some more data. So I open his chart to order these things, and at the VA, you actually get a snapshot right in the top left corner in CPRS of what his medical history is. So I'm opening the chart, I'm going to the order section, but I glance three things. He has PTSD, he's 33, he has PTSD, he has alcohol use disorder, and he was on a PPI. Those are the three things that catch in my eye. So how does these three data points, PTSD, alcohol use disorder, and PPI, I don't know if he's taking it or not, how do these things influence your thinking for what you can see before you? All right, I'll mute for a little bit. Those three things, how do they change your analysis so far? All right, there's a lot of really amazing thoughts in the chat. Gurmani, do you want to share yours real quick?
Yeah, I was just thinking, given the context of chronic alcohol use, think about liver failure, or like liver disease and associated portal hypertension, and then varices, both like esophageal varices in particular, can rupture and present with unrelenting vomiting, but be described as hematemesis, so blood in the vomit. And yeah, I guess we haven't really been given a true description of the vomiting aside from it being voluminous. So that's one of the first things I'm pulling on the past medical history to associate with. And if someone's on a PPI, you would think that that would be somewhat GI protective against blood as well. So I just kind of thought that, yeah, maybe if there's a potential that this individual is non-adherent for whatever reason with the PPI, then that could further like predispose to having a sort of presentation like this.
Yeah, I love it. I think that's absolutely true. And I think Wallace is asking a really important question that will clarify things. So Wallace, why is it so important to you to figure out painful versus painless?
So it wasn't mentioned if there's any blood in the vomiting, but I think that it becomes important because someone who has alcohol use disorder probably is not the first time that the patient is vomiting. So with a lot of retching, I would think more in line of some kind of Mallory wise tear in the gastroesophageal juncture, or depending on the amount of blood, if there is any, and or Boerhaave syndrome. So I think that it for someone who has a high likelihood of previous episodes, maybe daily vomiting, which today being more severe, I would think I think that this distinction it is important for think of causes.
Yeah, I completely agree with you. And I think when you go talk to him, you learn right away that he's been having a lot of pain, and he has a lot of epigastric pain. And it began 24 hours ago, right in the middle of his belly. He says he's had this before, but he's not sure what the cause was. It got better in a couple of days of just hydrating and relaxing. His vomit has been clear. He's been passing stool, has not had any fevers, chills, or chest pain. The pain is continuous in the epigastrium. If you're trying to build a differential diagnosis for what causes abdominal pain or vomiting in the context of alcohol, it's helpful to ask yourself, well, how will I get the answer? And there are three causes that will show up when you get the labs. And those are pancreatitis, liver disease, as Gurbani reminded us, and alcoholic ketoacidosis. Remember, that is a prominent cause of CT negative abdominal pain. So consider getting ketones or a beta HCG. When the labs don't show anything, we often render diagnoses of exclusion, including esophagitis and gastritis. And there are some rare things to consider, including the triggering of acute intermittent porphyria by alcohol, the triggering of Gilbert syndrome by alcohol, or even less commonly causing thiamine deficiency, which can usually has neurologic and CNS presentations, but can have a GI predominant presentation too. So I think that the sphere here is this person could have abdominal pain or epigastric pain independent of their alcohol use, but the alcohol elevates these diagnoses: pancreatitis, liver disease, ketoacidosis as your first pass on labs. And if the labs are negative, you'll entertain less common causes. So let me give you his exam, and then we'll reflect on what we learned in next steps. So he's acutely uncomfortable, sitting in the fetal position, holding an emesis bag, vomiting frequently in it. His cardiovascular exam is normal. His normal exam is normal. His abdominal exam, he's not peritoneal, but he has pretty significant tenderness in his epigastrium. There are no cutaneous signs of the disease at all. The skin is normal, and he has no edema and good pedal pulses. So, what do you all think is our pathway to a diagnosis here? What would you recommend as next steps to get an answer? And yes, Rafa, so no liver, no cutaneous manifestations at all, no pulmonary erythema, spider angioma, no jaundice stuff. Really good question. So what do you imagine our arc is here to the answer? I'll unmute and ask yourself, what would you order and do next to try to get diagnostic clarity for the patient? Oh, so many good thoughts. Thank you. Keep them coming. Keep them coming. Mariam, it's so nice to see you. Welcome to VMR. Do you want to tell us more about what you're thinking here? I think it's really, really important point.
Hello, thanks so much for calling me. So in terms of like, I was just thinking to like the main thing that you think of in the ED or like in an acute setting when you get a patient like this is, are you thinking medical causes or surgical causes? Because this will determine who you're gonna call, who you're gonna ask for help, what your next steps are gonna be like. So for him, I'm kind of interested to know like. A few people have mentioned to check for the chest x-ray, to check for guarding, ultrasound to see maybe if there's any perforation. So that would be like an emergency where you're going to need to take them to surgery versus other medical causes, which will take us to all the diagnosis for liver diseases or maybe other like cholecystitis. Even cholecystitis might be on the differential, but I'm not really sure so far. But yeah.
I think that's absolutely superb, my friend. I really do. I think you have to be very early about asking yourself, who do I need to lean on? Which consultant do I need to lean on? And that has to be a very important point early on in the case. And I think your specific thoughts here are superb. Are you still in Dubai or have you moved somewhere else?
No, actually, I'm doing a clinical elective in Rochester, Minnesota, in Mayo Clinic. Yeah,
amazing.
In anesthesia. Yeah.
I asked that because, like, oh my God, if you were in Dubai, it would be like almost midnight or something. So I'm
yeah, exactly. No, I'm actually like outside. The weather is like beautiful here, so enjoying the time.
And how long is your elective for? Is it 2 weeks, 4 weeks? How long is it?
Yeah, it's a month.
A month. Okay, amazing.
Yeah.
We'll have the best time. We're so glad that.
Thank you so much.
Of course.
Yeah.
All right. So there's some incredible thoughts coming in the chat. I think Ravi, your point about what you would do initially, really, really key is getting that EKG. I think that's absolutely superb. So this is the tricky part of this evaluation. It's about being practical. If you get blood drawn now, you will have the answer no sooner than 1 hour in most places in the world. Best case scenario, 1 hour. How quickly can you get a CT scan? 5 minutes, 10 minutes, right? So I would love for you to use your Zoom emojis and give me a thumbs up if you think the patient needs to go to the scanner before the labs return. Because you're all basically the words in the chat are lab, CT, but in what order? So give me a thumbs up in the next 10 seconds if you think the patient needs to go to CT before the labs come back, okay? I think I saw a total of 1, 2, 3. I'd say the majority wants to get a CT scan before the lab. Superb. There is no wrong answer here. It is wrong not to think about that and answer that question deliberately. I think it is the only way you can go wrong here is to not think it and think it actively. Do I need a scan before the labs come back? Okay. Now, the truth is most diagnoses in the belly are answered to the CT scan. Appendicitis, diverticulitis, cholecystitis. There's not many things that you can definitively diagnose before the CT scan comes back, right? So thinking expeditiously about getting that CT scan is really, really important. But let's build a list of things that we can diagnose definitively without any uncertainty before the scan comes back. So the question quite simply is, what are causes of abdominal pain that are definitively diagnosed by labs alone? So think that through. What can we diagnose without labs? Beautiful. I heard pancreatitis, alcoholic ketoacidosis, zoster. Yes. Keep going. There's more. What if you have a young female AIP? The labs that there, Amar will come back in days, so I'm not going to give you that one, although it's a genius try. Pregnancy, Gurbani, there you go, nailed it. Topic is really important. Okay, what if somebody has cirrhosis? What can you diagnose that causes abdominal pain in a patient with cirrhosis on a lab test? I didn't say blood test, I said SBP. All right, let me show you a proposed arc for abdominal pain. So you walk into abdominal pain and you know that your chances of getting an answer before imaging, which is the center of this world, is only if these things are possible. What will you diagnose on exam? Zoster, hernia, or a pulsatile mass suggestive of aortic rupture. That's the only thing you can be confident about. So a history and exam happens in the first 5 minutes. The only diagnosis you can make in 5 minutes is these. You could also make these diagnoses: EKG causing inferior myocardial infarction or bladder scan causing urinary retention. 5 minutes. This will take 1 hour. So here I told you the EKG is normal. I'll tell you the bladder scan is normal. There's no evidence of this on the exam. So the real question is, what is the pre-test probability that this patient has an ectopic pregnancy, pancreatitis, DKA, or SBP? What is the pre-test probability of these? And if you think it's low, you should get a CT scan. If you think you can wait, you should wait. So here, there's no right answer. No right answer at all, but that's the calculation that you have to do. When you see somebody with abdominal pain, in the first 5 minutes, the exam or the point of care testing will either answer if they have hernia, zoster, pulsatile mass, MI, urinary retention. First 5 minutes. By the way, first 5 minutes, 5 things. 3 on exam, 2 bedside tests. What are they? Zoster, hernia, pulsatile mass, EKG, bladder scan. 5 minutes, 5 things. The labs will then come back in an hour. And there are 4 key labs: lipase, ketones, beta HCG, and if a patient has ascites, to tap it. So the pretest probability will help you figure out if you should just scan the patient or wait for the labs. I opened his chart in more detail and learned that the reason he had epigastric pain before was because of pancreatitis. So I waited. Otherwise, I would have sent him to the scanner. 1 hour later, after 2 liters of normal saline and a lot of Zofran, about like 12 milligrams of Zofran, and nothing happened to him, by the way. His QTC was 600. He got 12 milligrams of Zofran, fine. Lipase comes back. Any guesses what the lipase is? I'll take guesses. Whoever gets closest to the positive lipase will get nothing, really. I don't have anything to offer you. An empty can of pineapple bubbly. 700, Marcus. Okay, Rafa, 3,000. Okay, Ravi, 2,000. Shema, 2,000. How Gurbani is going low. She's like, I don't believe this guy. I think he's messing with me. I think it's negative. It was, Rafa, you win an award. 3,200. Highest lipase I've ever seen. Have any of you seen a lipase higher than 3,200? Please impress me. 5,000, Ravi? What's the brief story on that?
Yeah, I was a patient with necrotizing pancreatitis, so very septic. So I guess necrosis may have inflated that lipase level.
Oh my gosh, that's incredible. 5,000. All right, you win, Ravi. Rafa, you're second. I'm sorry. I can't beat that. Okay. Y'all, what causes pancreatitis? What are the causes? Give you 30 seconds. Put in your favorite causes of pancreatitis in the chat. Amazing. Dale, do you want to unmute if you can and tell us? A really nice list there. Oh, no worries at all. Dale can't unmute, so I'll lead the list. Alcohol, gallstones, top 2 causes that gets you about 80%. Medications, IgG4 disease, familial. ERCP is up there, mentioned by Rafa. Ravi's favorite and Shema's favorite is scorpion bites. Wallace is sharing the I get smashed mnemonic, which is a superb. Marcus is reminding us that stones are a very, very big deal. Hypercalcemia, another really good one. Dale, I think you're the pancreatitis master. And yes, hypertriglyceridemia. Beautiful. Okay. So in him, he has alcohol use. So we're done, right? No? What would you do in real life? You have significant alcohol use. You have pancreatitis. I'll tell you the rest of his labs are completely normal, except his AST is about 80 and his ALT is 55. This is real life. You're giving him fluids. You're hydrating him. What would you do next? Okay, we want to get an ultrasound. Why? Well, put down your reasoning. Try to get it out in text. I know it's probably easier. Why do we need an ultrasound? Okay, Wallace, tell us more.
I think even though because of his past medical history of alcohol use disorder, I think that in terms of management, we should get a right upper quadrant ultrasound because of the management changes. You know, even though most patients with acute pancreatitis, you're gonna give IV fluids and analgesia and this kind of stuff. In the case of a biliary obstruction causing, we can have a lot of trouble. It can complicate with cholangitis and other things. So I think that because of management changes, we should rule out, because it is a prevalent cause.
Yes, absolutely right. Beautiful. You're saying it's the most common cause. It's about 40%. Alcohol is about 30%. It's the most common cause. It would change your management because then you'd have to remove the gallbladder or open up the sphincter. But check this out. So how do you actually make an educated guess? I would say that most people would tell you to think thoughtfully about getting an ultrasound when there are compelling features of alcohol use disorder. So you have to think about it. When you choose to get it, you might choose to get it if the amount of alcohol use is minimal. So if somebody gets a pancreatitis from alcohol, it usually is long-standing, severe, significant alcohol use. Patients are often people who consume alcohol on a daily basis. But I cannot tell you when or when not to get an ultrasound. I tell you that if you take care of 100 people with alcohol and pancreatitis exposure, and you get an ultrasound in 100 of them, you've probably gotten too many ultrasounds. When should you always get an ultrasound? Is when ALT is higher than the AST. And a disproportionate ALT elevation has a profound predictor for gallstone pancreatitis. You see that specificity in that study, it's over 90%. So when you should get it, plus minus. Not everybody. Not everybody. Maybe admission number 2 for him. You may say, you know what? He had ultrasound before, alcohol again, I'll stop. But you should always get it when the ALT is higher than the AST. So always pay attention. If you're moving towards not getting the ultrasound, you should definitely pay close attention to the ALT. Any thoughts on it? Any other thoughts or questions about that? Beautiful. Okay. Unfortunately, he ends up in the ICU 30 minutes later. Now, I would love for you all to predict what happened. Why did he end up in the ICU 30 minutes later? By the way, if you all thought we could like sit back, relax, we have an answer now, no problem. What happened? Why did he go to the ICU? Shock. Okay, beautiful. What else could have happened to him? I love it, Rafa. Rafa's like, all the complications of pancreatitis. Yes, correct. Actually, well, sort of. Oh, Dale, he nailed it. There are other complications we need to think about. Okay, Marcus, ACS, Ravi, hemorrhage, Alex, aspiration. Incredible. Okay. Maritzi syndrome. Okay, that is that's a lovely thought, Ronnie. So patients with pancreatitis can get hypotensive for a variety of reasons. I'm going to share with you in the chat a Twitter thread from this morning where the wisdom of folks from Twitter was superb. So there's a long DDX, but I will put it here for us to explore. Here you go. But it's also a good opportunity, in addition to reviewing shock, which here is basically all the list of causes of shock. I just put it in here. You have to think about some other complications of pancreatitis. So how do you all break down, in addition to getting shock, what are the other complications of pancreatitis? What do y'all think? Awesome. So ARDS. Ravi, do you want to remind us what you retain in your mind about ARDS and pancreatitis?
Yeah, one of the pathophysiology books I read a long time ago was a very remarkable reason with the release of lipase circulating in the blood going up all the way to the lungs, it can actually impact surfactant, and that may actually is one of the causes of ARDS.
Beautiful, superb, awesome. Rafa, beautiful thoughts. Tell us more.
Oh, actually think about like things like pseudocysts when you're treating this patient, like giving IV fluids, giving anti-emetics, and for some reason, like 48 hours, he's not improving or she's not improving. So you have to get some imaging, you know, to make sure there's no complication going on, like a pseudocyst.
100%, beautiful. On that point, I think we should just emphasize, I glossed over it. We have made the diagnosis of pancreatitis here. You need two of three things: epigastric pain and lipase elevation greater than 3 times normal, as Marcus reminded us earlier. And then you need CT imaging of pancreatitis. So you need 2 of these 3. Pain, lipase are sufficient. And in all comers, about 80% of people will have pain and lipase elevation. So 20% of patients need a CT scan for the answer. Just so you know, CT is not perfect. So CT is negative, falsely so, in about 5% of patients who usually have focal pancreatitis, usually in the tail, and an MRCP can then confirm the diagnosis. So CT is not perfect either, but 80% get the diagnosis with just abdominal pain and CT alone. But here's a quick review of the complications of pancreatitis, which are best conceptualized by the time course. So the acute complications of pancreatitis are all about leaky vessels. Leaky in the lung, leaky in the kidney, and so you get hemoconcentration, acute kidney injury, distributive shock, they become malfunction and leaky. And they can leak so much fluid in the belly that you can get abdominal compartment syndrome. You could also get fat metabolism issues from the digestive enzymes causing a hypocalcemia and even a fat embolism. As you can see, the acute complications are much more systemic, greater than local. But there are some local complications. You can get an ileus, you can get gastric outlet obstruction, but most importantly, you can get inflammation in the vessels around the pancreas causing thrombosis or aneurysm formation. But as Rafa reminded us, as you go with more time, the local complications start to become more than the systemic complications, where you could get fluid collections, necrosis, fistula formation, and eventually exocrine and endocrine insufficiency. So what general themes should you remember? The more closer you are to the disease onset, the more systemic the complications are. Systemic complications are a vascular leak. And then after time kicks in, the local complications take over. The most important local complication early on is vascular, either bleed or clot, as Ravi reminded us very early on in this case. Folks, he went to the ICU for alcohol withdrawal. In the midst and craziness of focusing on his pancreatitis, completely forgot about the possibility of alcohol withdrawal. He had sat in the ER for a couple hours with no benzodiazepines, which is an error and a mistake. And the second or third time we went to check on him, he had tremors, hallucinations, tachycardia, hypertension. And unfortunately, despite some Ativan and the ER, it wasn't enough. And so he went to the ICU. What is this phenomenon? This phenomenon is well known in the trauma literature. It's called a distraction injury. But for us, it's called a distraction diagnosis. When somebody has so much pain and nausea and vomiting, you're so focused on it. But anytime that you are diagnosing anything that has the word alcohol in it, alcoholic anything, you have to step back and say, hey, does he have a complication of this diagnosis, or is it the alcohol itself? So you always have to be on your toes. Patients can have multiple diagnoses. In this case, yeah, he did. All from the same thing, alcohol resulting in withdrawal and alcoholic pancreatitis. Very, very humbling case. We're at the hour, so I will stop there, mute for 30 seconds to see what questions you all have, and I will answer them. No history of withdrawal. Never. First
Yeah,
time.
the reason why I was asking is if he had on his medical documentation history of DTs, that should instantly set off that. That's a high risk for recurrence.
100%. I couldn't agree more. Yeah. You know, it's amazing. We all are growing, and as what Seema said earlier, you know, like there's so much to know and remember that it's impossible to track it all. But yeah, Rafa, go ahead.
When I saw the past medical history this patient was on PPI, I thought that maybe he had a GERD and
Yes.
a structure leading to the vomiting. Why
Yeah.
didn't you think about that? What took you away from that diagnosis?
Yeah, you know, I think it's because you found something else, right? Like you remember when we were talking about alcohol-related complications. If you find either pancreatitis or hepatitis or ketoacidosis, you tend to focus on that as the diagnosis. The other thing is that most strictures don't cause epigastric pain. They cause dysphagia. And so when somebody is vomiting profusely, the lesion, if it's in the GI tract, tends to be distal to the stomach and the esophagus. So if somebody has an acute esophageal disease, they don't vomit so much, they have a lot of dysphagia. So yeah, I think the combination of those things were sufficient for me, but we're making assumptions, right? We're saying, oh, just because you have one thing means you don't have another thing. But yeah, those are the reasons. Other questions?
Just one question. When you took his history, did you ask when was his last drink?
Yes, I did ask that. Thank you. That's a really important one. He had actually drank 30 minutes before he came to the ER. And
That's really soon.
Yeah. You know, I will share that in the ER, that's not uncommon. It is so hard for patients to come seek care in the emergency room, for everyone, including ourselves. And for patients who have frequent use of substances, there's an even more powerful anxiety, and that anxiety can be tempered with using the substance before coming to the emergency room. I see that phenomenon a lot. So when patients drink a lot, they're so worried that they're going to withdraw in the emergency room, and so they drink right before they come. And some patients actually have a lot of alcohol on their person, and so you have to be very, very careful of that. If you need control of the situation for medical reasons, you probably need to ask them to go through their belongings, which most emergency rooms do. There's a question in the chat from Dale, and let me answer that real quick, and then I'll come to Alex next. Just for everyone else listening, so Dale is wondering, how would you manage this in terms of stabilizing if you're unable to get the vomiting under control with medications? Is intubation the next step? So that is a fantastic question, and I will say if you are unable to control vomiting with medications, that must mean that you have not found the cause. Vomiting, nausea and vomiting, the medications that we have in our toolbox are so powerful that if you have addressed the underlying cause, the vomiting will remit. So if this happened, I would pursue intracranial hypothesis, repeat an EKG. All my impetus will be diagnostic in this case. I don't think that anything you can do, intubation, all that, will stop the problem unless you reverse the cause. It's a really good question. Yeah, Alex, go ahead.
Thanks so much for the case, as always. To Ravi's point about how this guy doesn't have a history of alcohol withdrawal, and how his last drink was within the day of when he presented. In hindsight, would you have given him a medication to try to preempt try to prevent alcohol withdrawal while he was down in the emergency department, or is this somebody that you would have not treated?
No, I don't know if there's much data on this. I actually don't know. My practice pattern is yes, I give people 25 or 50 of Librium if I'm worried that they're going to withdraw. And I think that if I wasn't so washed away by the severity of his initial presentation and his symptom complex, I probably would have. So I do believe in the role of preventative therapy. Like if somebody's telling me that they're having alcohol 30 minutes before coming here just to be able to manage their ER visit, that often is enough of a trigger for me to give them some Librium. Why Librium? Because it lasts long enough that I think as an average ER visit is about 3-4 hours for people. So at longer acting benzodiazepine like chlordiazepoxide is what I go to, but that is definitely not evidence-based.
It's interesting. I mean, at our hospital, what we, but at least over the past like year and a half or so, what we've tended to do for the most part is give that same dose of Librium, but really for the most part to people who have a history. So for somebody like him, I wonder if we would have seen the same problem even if we didn't get away by everything else.
100%. I think you certainly have more license to miss this diagnosis if it hasn't happened before. I think, as Ravi said, for most people, they would immediately see it in the medical history and act on it. But again, for everyone who has DTs, there was a first episode, right? For all of them, every single one of those patients who's had recurrent disease, DT, had their first episode at some point. Yeah. Awesome, y'all. All right, I will pass the mic to my dear friend Shema for the teaching points.
So thank you so much, Ravi, for this great case. And also for the great discussion. I learned so much, especially always when it comes to these fluids, I'm always so unsure. So thank you for the brain gains again. So just a moment, I have to see the whiteboard. You hear me? Yeah, okay. So if we have a patient with persistent vomiting, we consider toxins and occlusion, or also think of a direct irritation of the GI tract, something like an infection if it's acute, or also psychological triggers like stress. And then we had this anatomical approach of vomiting, consider the cranial nerves, the area postrema, like the area postrema syndrome and NMOSD, vestibular or GI. And then we had the case of tachycardia and hypotension, and we were talking about what to do in this case. And then coming to long QT syndrome, we learned that we don't have to stop giving anti-emetics because the rate of adverse effects of these anti-emetics is very low. And then the question came in which fluids we can use. So we have normal saline solution, and there are three big points to give it because it is basically the habit. Also, it's cheap and it's usually in the stocking, and you can give it when you expect an alkalosis. But there are also some side effects, like it is associated with a non-anion gap metabolic acidosis, and it can also cause a kidney injury. Then there are these balanced crystalloids like a lactate ringer or plasma-like, and the colloidal solutions like albumin, but there's a side effect of cerebral edema that I didn't know about. So we usually avoid these colloids in most situations. And then talking about current diseases associated with alcoholic use disorder like portal hypertension, liver failure, Mallory-Weiss or Burr-Harvey syndrome. And then talking about abdominal pain and alcohol use disorder. So in the combination, we consider pancreatitis, liver disease, alcoholic ketoacidosis, and also knowing that alcohol use can trigger acute intermittent porphyria or thiamine deficiency. And if we have abdominal pain that is being just diagnosed by the labs, we're thinking of alcoholic ketoacidosis, zoster, hernia, a pulsatile mass, adrenal crisis, or porphyria. And usually we perform an EKG or bladder scan because it's very fast. And usually in the labs, we would wait for, so we would look for lipase, ketones, beta, HCG for a possible pregnancy, and TAP if we have something, considering something like a spontaneous bacterial SPB, peritonitis, sorry. And then thinking of pancreatitis complications. So in acute state, we are always considering a vascular leak leading to hemoconcentration, acute kidney injury or abdominal compartment, and also hypocalcemia or fat embolism. The local complications could be an ileus or generally an inflammation of vessels causing thrombosis. And in chronic states, think of a necrosis, pseudocysts, and also exocrine and endocrine complications. And we were also talking about that pancreatitis can lead to ARDS because of the inflammatory cytokines that are being released. And if we want to diagnose the pancreatitis, where are these three criteria? So we need to have abdominal pain, lipase 3 times upper limit, and abnormal imaging. And we also learned that CT is negative and can be negative in focal pancreatitis, and 80% of pancreatitis can be just diagnosed with pain and the scan. And we also learned that acute esophageal lesion rather causes dysphagia than vomiting. And for the prevention of alcohol withdrawal, give Librium, or I wouldn't say clometiazole, but yeah. So thank you very much and hope to see you again soon tomorrow.
Y'all are amazing. Thank you for that superb recap. I don't know how you participate in the chat in my random, unpredictable questions and do the teaching at the same time. Absolutely
Thank you.
masterful. All right, y'all. See you soon. Thank you again for hanging out. Happy Saturday.